I would like to welcome Dr. Sharma from the Johns Hopkins University, who's going to talk about viral mimicry and how it changes the immune landscape in osteosarcoma. Dr. Sharma.
Okay, thank you so much for giving us a chance to present our data. We had a great brainstorming session throughout the day, describing the pathological conditions and the different treatment modalities being used in these cancer settings. My topic is around the same line where we are trying to reprime, actually priming of tumor microenvironment in patients with pulmonary metastatic osteosarcoma. For background, we know osteosarcoma is most common bone malignancy, occurs in children and adolescents. And this is a standard treatment regimen for this patient, which typically utilizes 2 cycles of doxorubicin and cisplatin, alternating with methotrexate in the neoadjuvant setting, and then resection of tumor specimen and assessment of percentage of necrosis, and then continuing 4 more cycle of same agents in the adjuvant settings. This is typically successful at controlling the primary localized osteosarcoma in up to 70% of the cases. However, patients who present with pulmonary metastatic disease upfront or patients who develop metastasis later in their course are associated with the poor prognosis and survival. As you can see in this Kaplan-Meier curve, which is showing the overall survival of patient with metastatic disease, which is kind of quite very less than the localized osteosarcoma. And this is the reason precisely we are targeting these tumors to improve the care of these metastatic osteosarcoma lesions, to improve the care of this vulnerable group of patients. So to address this problem, we designed this clinical trial, which is a multi-center phase 1, phase 2 clinical trial, sponsored by National Pediatric Cancer Foundation, to assess the safety and feasibility of nivolumab in combination with 5-azacitidine, and then in patients with recurrent and resectable osteosarcoma. The secondary objective of this trial was to improve the event-free survival of these patients by 40% compared to the historical patients. The trial uses the anti-PD-1 therapy, nivolumab, in dose level 1, or combined with the 5-azacitidine treatment, which is DNA demethylating agent, for 2 different dose levels, at 2 different dose levels for 1 cycle in the neoadjuvant setting, and then followed by resection and assessment of percentage of necrosis, and then following the same reagent for 12 more cycles in the neoadjuvant settings. The rationale of this approach is that, as we know, DNA demethylating agent can evoke the viral mimicry phenomenon by synthesizing the endogenous retroviral elements. Also, this agent can also synthesize the cancer testis antigen, which are highly immunogenic in nature and can make tumor cell more visible to the immune cells. As the patient went through the clinical trial, we obtained the biospecimen, including peripheral blood, serum sample, and tumor specimen, which were subjected for the different interrogation processes to assess the treatment-induced systemic immune responses, as well as the tumor modification in the tumor microenvironment. Okay, to evaluate the treatment-induced systemic immune responses, we have estimated the cytokines level in these patients, which was quite like long-term kind of cytokine analysis. While analyzing this data, we actually combined the 2 different dose levels of 5-azacitidine and comparing with the nivolumab arm of patients. Here red trend line is showing the patient who received the combination therapy, and the blue trend line is showing patient who received the nivolumab monotherapy treatment. These results shows that the patient who received the combination therapy is having the longitudinal sustained elevated level of IFN gamma and CCL5, which consistent with the immune activation and type 1 interferon, type 1 inflammatory responses to these patients. To get the more biological information from the cytokines data, we further calculated the cytokines ratios, knowing the different distinct function of these cytokines. The patient who received the combination therapy showed the more pro-inflammatory cytokines responses, you can say, and also more T cell activation and effector function, as you can see with the different ratios. These very same set of patients who received the combination therapy also showed more skewing of Th1 population and more cytotoxic potential. We also stained the PBMCs and performed the flow cytometry of these PBMCs to demonstrate the treatment-induced changes in dynamics of systemic immune responses. These results showed that the patient who received the combination therapy exhibit more T helper cell frequencies, CD4, more CD4 frequencies, as well as the classical dendritic type 1 frequencies with diminished frequencies of myeloid compartment, suggesting that these patient has a higher T cell mediated, T helper cell mediated immune responses. Okay, this is our previous study where we have shown that these patients, especially patients with the pulmonary metastatic lesions, they have a deployed immunosuppressive mechanism in their tumor microenvironment and precluding the immune cells to infiltrate in the tumor microenvironment and facilitate tumor cells to grow much faster. As you can see in these micrographs, sorry about these figures because they are more crowdy, but most of the immune cell densities are at the periphery of the tumor, while tumor center is lacking or devoid of the immune cell infiltration. To correlate this finding, we assessed the immune cell infiltration of trial specimen and compared the immune cell infiltration density with the historically collected osteosarcoma lung metastasis cases. And I'm here showing you the ISC staining of CD8 marker in the trial specimen. The analysis was conducted by the HALO software, which is basically giving us a density heat map, which is reflecting the positive CD8 positive cells and the distance from the interface. The histogram obtained from this analysis, as you can see in the extreme right, is indicating the number of positive cells on the y-axis and the distance from the interface on the x-axis, where 0 is, or O is suggesting the distance from interface. When we compare the immune cell densities between trial specimen and the historically collected osteosarcoma lung metastasis cases, we have found that trial specimen shows more CD8 infiltration and PD-L1 expression in the tumor compared to the historically collected osteosarcoma cases, lung metastasis osteosarcoma cases. Okay, so since these patients were subjected to received the nivolumab plus 5-azacitidine treatment, so expected to induce the global DNA demethylation at the systemic and the intratumoral level. So what we have done, we have performed the methylation analysis on PBMCs and tumor specimen collected from these patients to assess the degree of treatment-induced methylation changes. In this volcano plot, as you can see here, the methylation profiling of PBMCs is dichotomizing the hypomethylated and hypermethylated sites based on top 500 delta beta values. Similarly, the heat map from this analysis is also suggesting that the hypomethylation of top 1,000 CpG sites, comparing the screen time point PBMCs with the post-azacitidine time point PBMCs. Even more interesting, when we perform the same analysis on resected tumor specimen obtained from this trial, after one cycle of therapy comparing nivolumab with nivolumab plus 5-azacitidine group, in this heat map you can observe the noticeable amount of hypomethylation pattern in tumor who are received from combination treated patients, which was the whole intention of this treatment regimen, treatment strategy to induce the hypomethylated condition. To further assess the epigenetic responses on the tumor microenvironment, we have done the bulk RNA sequencing of the tumor tissues. In this box plot, you can see the normalized transcript per million values on y-axis for canonical marker of interferon regulatory genes, comparing the two treatment group. As you can see here, we can appreciate the higher number of IRF7, ISG15, and OASL genes in patients who received the combination therapy. When we deconvolute the RNA sequencing data from these very tumors, what we have found that patients who received the combination therapy is actually showing more immune fraction for B cell, dendritic myeloid cell, and NK cells, indicating that these tumors have higher capacity of presenting the antigen to the immune system. Similarly, it can also indicating that higher cytotoxic or innate immune system deployed in these trial specimen who treated with the combination therapy. Okay, so this RNA sequencing data was further deconvoluted by another algorithm, which is Excel algorithm, to actually obtain the gene score of these tumors, which is you can see for the different immune cell compartment. As you can see in the different rows of these heat map, as you can appreciate that most of the combination treated patients are on the left side of this heat map, indicating the more inflamed TMEs of these patients. Similarly, when we compare the progression-free survival of these patients, the most striking observation is that the patients who are extreme left of the heat map are more inflamed in the immune signature, and they have the longer progression-free survival despite not having this different statistically significant. We are still probing the data from these very two patients to learn more about them. What interesting observation we have also found when we review the ISC of these two patients, what we have found that these tumors contain lymphoid aggregate or tertiary lymphoid structures. And as you can see in these micrographs, these tertiary lymphoid structures having more immune density of CD8 cell, which is in purple color, and more PD-L1 expression, which is in brown color. This has piqued our interest since there is a growing body of knowledge describing the relevance of these structures in immuno-oncology field and association with the better outcome in patient and responses to the immunotherapies. Going back to the main premise of combination therapy, as I already mentioned, that 5-azacitidine treatment can also induce the cancer testis antigen, which are highly immunogenic in nature and can evoke the immune system by making tumor cell be more visible. So we have plot the heat map using the 1100 CTA genes by RNA sequencing data. As you can see, there is a clear dichotomy of CTA expression in these tumors. And we classify these tumors based on CTA expression is CTA low and CTA high expressing tumor. And this CTA expression is irrespective of the treatment given to these patients. What important observation, we have also found that when we analyze the RNA-seq data by deconvoluting this RNA-seq data for different immune cell fraction, we have seen the high CTA containing tumor has more immune response driven by high CD8 immune fraction in these tumors, along with slightly higher immune fraction for M1 macrophages and NK cells, suggesting the high CTA containing tumor associated with the higher cytotoxicity of the tumor cells. We further corroborated this finding at the ISC level, and the results what we have found that high CTA containing tumor also has the higher infiltration of CD8 positive cells in these trial specimen. Okay. In this box plot, as you can appreciate that in addition to higher CD8 immune signatures, these high CTA containing tumor, which are in green color for high CTA containing tumor, these tumor also have the higher expression of effector molecules, which are IFN gamma and perforin, along with the higher expression of co-stimulatory molecules like TIGIT, ICOS, and PD-1. When we compare the PBMC's flow data based on the high CTA expression, what we have found that the patient who express the high CTA signature in tumor, they have the higher frequency of PBMC's CD8 T cells at the peripheral level also. Interestingly, what we have also observed when we compare the progression-free survival of these patients based on the high CTA and low CTA expression, the patient who has the higher CTA signature, they perform better in the progression-free survival compared to the low CTA expressing tumor. So in conclusion, we provided an evidence of systemic and intratumoral immune responses. We have also observed the altered methylation profiling of PBMCs and tumor tissues after 5-azacitidine treatment. We have also documented an induction of interferon regulatory genes, interferon signatures, and immune cells. We have identified a couple of patients who are behaving as an outlier with immune cell aggregates or perhaps tertiary lymphoid structures. We have seen the association between CTA expression and tumor immune landscape and progression-free survival of these patients. I thank you all for your attention and for patient, also particularly to the patient and their families who participated in this trial, and National Pediatric Cancer Foundation for sponsoring this trial. Thank you.
Thank you so much, Dr. Sharma. Any questions?
Thank you for your talk. I was curious if you've thought about any like in vitro or in vivo analyses you could do to try and identify if there's a specific immune cell type that is contributing to the responses you're seeing.
Yeah, great question, seriously. We haven't come to that point right now, but we have specimens, PBMCs and tails also, the limited number for the tails. But yeah, definitely we can plan accordingly to demonstrate some of the aspect of these observation to extend that and at the individual level.
Any other questions for Dr. Sharma? While you're thinking of 1-azacitidine, 5-aza is actually a methyltransferase inhibitor, have you ever looked at an epigenetic level if there are any changes in methylation of those genes and in these immune cells?
Genes to regulate the methylation? No.
Since you're looking in patients treated with AZA, did you look at any epigenetic changes? Because AZA itself is a methylation transfer.
So, as a global, we have seen the changes in methylation pattern at the systemic level by observing them in the PBMCs and the tumor level also. I'm understanding your question correctly, is it the question like, or something else? Because
I think you showed some sequencing data. I was wondering if you did any
So,
methylation analysis.
Yeah, we did the epic methylation analysis where we have shown that the data which is from the PBMC, even after one cycle of the methylation. That was the beauty and that was the intention of this trial. Overcome the immunosuppressive environment. Generating the
Thank you. If there are no more, no, thank you, you did answer. Sorry, I missed that. If there are no more questions, please join me in one more round of applause for Dr. Sharma.